So I'm actually really excited to talk today about family-based therapy. Um, just for a little bit of background, I actually came into the world of eating disorders from more of an individual therapy perspective. That was my training in graduate school, and that's actually was my role when I started working at the program at Children's Hospital about 10 years ago. We had people that did family therapy. It was not me. And so when we had folks that came to us to teach us about family-based therapy in 2008, it was something quite new for me, this idea of moving my approach from doing individual work with teens with anorexia to using a different approach. And I hadn't bought in at all when they first came to talk to us about it. It was something I hadn't heard too much about yet. However, I will say just from my perspective, it's represented a huge strength in my practice, and I now do almost exclusively family-based therapy when working with children and teens with anorexia. And instead of feeling frustrated and overwhelmed and like I wasn't being helpful, like I did a lot of the time when I was doing individual work, I feel that most kids do get well using this approach, and so I feel really confident when I meet a family for the first time that they're going to get through this, their child's going to get well, and it's not going to be this years-long, drawn-out process. They're going to get well quite quickly. So it's very exciting for me as a clinician to feel very confident about it, and that some of the, there's a lot of great research behind it too, but research is one thing, and then personal experience with an approach really makes me feel very excited about it. So I'm pretty pumped. I'm also excited to talk about it today because I think it's really relevant for your situation. It's an outpatient approach, and it doesn't require a large team. If you don't have a large team, that's okay. What it requires in the bare bones form would be a medical practitioner, a physician of some sort, and a therapist of some sort. And the exact training of those people is less important than they're learning about this model and applying it. So I think it's a really flexible model. If you have other people that you can pull in as part of your treatment team, that's awesome. It's great to have more people to consult with. But if you don't have it, that's fine too. This approach does not require a large team. So great. There's at least 3 decades of research that supports the use of general family therapy in the treatment of adolescent anorexia nervosa. But more recently, research has focused on this particular type of therapy. You might have heard it called the Maudsley approach, and in the States it's called family-based therapy, or FBT. Just can I do a quick scan of the room? Have folks heard of this approach before? With a show of hands. Okay, many people have heard of it. Excellent. It's actually the treatment now that has the most research support behind it for child and adolescent anorexia nervosa. There are quite a few clinical trials. This one that's up here on the board is the one most often cited. I'm going to very briefly talk about it, but we don't have time to talk a lot about the research support. Essentially, Locke et al. In 2010 randomly assigned adolescents to FBT or an individual therapy called adolescent-focused therapy. The adolescent-focused therapy is an individual therapy that does have weight-related goals, but focuses more on emotional tolerance and identifying emotions. And they found that at the end of treatment, I know this is a confusing chart, but I'm going to ask you to focus on the black part at the bottom at the 12-month follow-up, which is the full remission group. So you'll see that folks who did the adolescent-focused therapy, we had fewer that entered full remission after 12-month follow-up after treatment than those in the FBT group. Still, is it 100%? No. We actually don't have a silver bullet treatment for child and adolescent anorexia nervosa. This is a tough disorder to treat. But so far, this looks like the best that we've got. Is it for everyone? No, it's not for everyone, but it's a great starting point. And I think that a great question to ask is, if you're not using this approach as your first line, what else are you using and why are you not using this approach? And sometimes there's great reasons not to use it, but it should be what you consider first. There's also some newer research looking at this treatment in bulimia nervosa. The outcomes aren't as strong as in anorexia nervosa, but it is an emerging treatment for adolescent bulimia nervosa, as is CBT. And we do need some comparisons between FBT and CBT. So what is FBT? Well, early family therapy models tended to focus on an explanatory model of the eating disorder, so looking to the family and saying, I wonder what family factors led this child to have an eating disorder. Maybe it was rigidity in the family, and conflict avoidance, and that's what led to the anorexia. And the idea behind the family therapy was to then kind of root out what these root causes were within the family, change those, and then we're not going to have the eating disorder anymore. However, there actually isn't any research support for the idea of a psychosomatic family causing eating disorders. And there's little support for the idea that certain family behaviors cause eating disorders. But unfortunately, the idea that parents are significant in developing eating disorders does tend to stick around a little bit today. And one reason might be related to that Eisler picture that I put up earlier, that we notice that families where their child is very ill sometimes tend to act similarly to one another. And it's tempting to look to that as the cause of the eating disorder. Well, look, the mom and the daughter are really enmeshed, and the parents are really anxious. Maybe that's why they have the eating disorder. But it's more likely that families in which a child has a life-threatening illness, they're stressed and they're kind of freaking out, and they're not acting the way they would normally act if their child was well. So this new perspective, which is what FBT is based on, is that a model that looks at what caused the eating disorder is less helpful than looking at what's keeping this eating disorder going in the family. What are the things that are helping it stick around? And so that's what I'm going to talk about today. FBT, which is the treatment I'm going to talk about today, was manualized by James Locke, who's a psychiatrist at Stanford, and Daniel LaGrange, who's a psychologist at the University of Chicago. And they have numerous research studies. If you Google Locke and LaGrange, or if you look on the maudsleyparents.org website, which is on your handout list of resources, there's lots of great articles supporting this treatment on there. And these are some great manuals as well. Some of you I know already know about the book, Help Your Teenager Beat an Eating Disorder. This is intended for parents, but it's great for clinicians to read too. And it outlines this treatment approach for parents. And then the newest treatment manual is this 2013 Center one, and that's the one for clinicians. So the basic theoretical principles of this approach are that the adolescent with anorexia is seen as ill and out of control around eating, and not as in control of her behavior. And Riley and her mom talked about this really poignantly this morning, the idea of externalizing the eating disorder. So what you want to do as a clinician is help the family all get on the same page, including the child with the eating disorder, all on the same page that we're all fighting the same enemy, the eating disorder. This eating disorder has taken over the family. It's making everybody act in unusual ways. It's taken over your child, and that's why he or she is acting really differently than usual. And we all need to work together to get you restored back to health. Sometimes kids really find this approach helpful, and sometimes they don't. Almost all parents find the approach of externalizing the eating disorder helpful. So it may be more for the parents at the beginning. Sometimes as the child becomes more restored to health, they also appreciate the approach, and some hate it forever. That's okay. Another basic principle is that parents need to take charge of normalizing the eating behaviors for their child. And the therapist really actively states, yes, I know this is really out of sync with normal development for your 16-year-old or your 15-year-old or your 19-year-old. Normally you wouldn't be taking charge of her meals, but she's really unable to feed herself in a developmentally inappropriate way, and she's going to die if we continue to allow her to feed herself in this manner. So we need to do something different. She can still pick out what earrings she's going to wear and what color she wants to dye her hair and all this other stuff, but not food and eating. And when you're well and the eating disorder is not making the decisions for you, then you'll get to make these choices again. What about motivation? This is a question that people often ask. This approach does not assume any motivation to recover on the part of the child, which is great because part of the diagnosis of an eating disorder requires that they're not really that motivated to change, so we don't have to wait for that. We can just carry on and start with treatment. The great thing is, once people start eating and they can think more clearly, some, but not all, kids do feel more motivated. I'm not naive. I'm not thinking that every single kid is going to, have a few good meals and all of a sudden become motivated, but it's surprising how many kids do become more motivated once they're hydrated and well-nourished. This is in red here for this approach. The focus remains almost exclusively on the eating disorder symptoms until they're eliminated. Yes, this child may be perfectionistic. Yes, he may be extremely anxious. Yes, she may be very shy. These are real problems that will need to be addressed later, over here. So we wait and we stay around the eating disorder symptoms until they're eliminated or managed well enough that they're not causing major problems every day. So we don't ignore these other problems. Sometimes people think that this approach doesn't focus on anything except for eating, which is true for the beginning phase of it. But we're not ignoring the other problems. We're just saying, let's hold off on treating those until later. The therapist also acts as a consultant to the parents rather than as a didactic expert spreading his or her wisdom. So you have to walk kind of a fine line because yes, you are an expert on eating disorders, so you don't want to be too coy. And if there's something very simple, some simple suggestion you could give, I think it's okay to give it. But your ultimate goal is to really empower parents. Most parents want the best for their kids. Most parents have some decent parenting skills. So what you want to do is help the parents access the skills that they have to parent their children in other areas of their life and help them apply them to this new and very unusual situation that they're now facing. So if you just tell people what to do, then you become Dr. O'Brien who knows all. We couldn't have gotten through this without you. You saved us. Thank God you're here. That's not what you want. What you want is you're reminding the parents of the skills that they already have. So you need to have a healthy dose of humility and not be too didactic and not provide all of the solutions. And that can be really hard because people want solutions. They're scared, they're anxious, like, please tell me what to do, this is happening. So it can be a real pull to give solutions. It also says parents need to figure out mutually agreeable solutions. This underlines the importance of helping mom and dad or whoever the guardians are in this situation to work together. More about that later. Who are appropriate candidates for this therapy? This is from the manual. This isn't necessarily how we roll in real life practice. So 18 years of age and younger, there are people trying this on kids that are a little bit older with modifications. Diagnosis of a restricting eating disorder and needing to gain weight. Living at home with their family, and family just means all individuals living in the same household. So sometimes we have grandparents or aunts and uncles or even close friends that come in and are involved as well. The family must be committed to the therapy and attend sessions reasonably frequently, but part of your role in the assessment process is to help to get the family committed to the therapy because most people aren't going to sign up for this voluntarily. Weight at or above 80%, haha. That hardly ever happens. Parents able to tolerate working together to help their child, and again, that's part of your goal as a therapist is to help them understand how important this is, that they work together, even if they don't normally get along too well with each other. And a lack of extremely high level of parental criticism towards the child. That would be one where you might want to consider a different therapy approach if the parents are frequently and unable to change high levels of parental criticism towards their child, and it's predictive of very poor outcomes in this treatment. Another difference from treatment as usual is that there's one lead therapist. So if I was the psychologist or the therapist working with the family, I would be the lead and the case manager in that situation, with other professionals such as the pediatrician, dietitian, or psychiatrist working as a consultant to me and or the family. So this can be a little bit different, often where the medical professional might be considered the lead therapist, and it requires a lot of communication. So Dr. Lam and I both do this in the outpatient department. We talk to each other every afternoon that we're seeing patients. We're up and down the hall talking to each other. We've been known to text each other from sessions. We'll call each other in. We work very closely together so that we know exactly what's going on with the child and the family. If you aren't in the same hallway as each other, you can phone each other, but it does require a lot of close communication. It's also different in that we generally don't recommend individual therapy during the first phase of treatment, but that can be deferred to later in treatment if needed. And the therapist remains very neutral regarding the underlying cause of the eating disorder. Another difference, which is again in red, is that the therapist and the treatment team are not gentle and reassuring about the gravity and severity of the eating disorder. One thing that works in this treatment is you're actually raising parental anxiety enough that they're ready to take action. If you have the most anxious family ever in front of you, you're not going to try to raise anxiety even more. But if they seem kind of like, well, maybe this isn't that big a deal. It's really important that she does all of her exams, and she's on the basketball team, and that's really important to her, so we don't want to, you're going to need to do some anxiety raising about how serious this is. Another difference is that the therapist is the one that weighs the patient, and this is quite different from many therapists and something that you might not be used to doing. And that's also your time to meet a little bit one-on-one with the child, depending on how engaged they are with the treatment process. That could be as short as 5 minutes one-on-one to as long as, I even go up to half an hour sometimes later in treatment with a kid who's really engaged with the process. And then that weight is shared with the patient and family and graphed to measure progress throughout therapy. So this is the information that the parents need to see how things are going in therapy. And the parents are very actively involved in supporting their ill child to eat. All this hospital stuff that we heard about this morning, the parents are doing that at home. They're selecting the meals. They're doing all the meal support, 3 meals and 3 snacks a day. It's not maybe it would be great if you could sit down for 1 meal together. It's you're all sitting down together for 3 meals and 3 snacks that are 100% supervised. So what does this actually look like in practice? It's a 20-session treatment protocol. Since we're not in the States, we can be a little bit flexible about that. And sometimes it goes a little bit more or sometimes a little bit less. And it's divided into 3 phases. The focus of phase 1 is reestablishing healthy eating. In phase 2, it's helping the adolescent to eat on her own, so returning that management over food, eating, and perhaps exercise to the adolescent. And phase 3 is family and adolescent developmental issues and termination. You'll notice that that is a very short phase in this treatment approach. Does that mean everything is awesome? Sometimes, yeah. Sometimes a kid that seems super anxious and you think, wow, they're really going to need a lot of work after treatment. Well, you go through this and they're well nourished and they actually don't need a lot of follow-up afterwards. And other kids have sort of a pre-existing obsessive and compulsive disorder or social phobia, and you'll want to then refer on to an individual treatment for that once you've finished family-based therapy. The very first meeting with the family is the most critical of this treatment as it sets the tone for the whole therapy. And as a therapist, you're walking a very fine line where you're wanting to engage the family in therapy. So you're being warm and engaging each member of the family, including siblings, learning a little bit about them. But you're also being very grave and concerned, and you may use terms like starvation, that their child could die, really emphasizing the severity of the illness. You want to obtain a history from each member about how the anorexia is affecting them and their family, and obtain some preliminary information about how the family functions. By the end of this first session, you will have weighed the patient and started your weight graph. Hopefully you will have engaged the family in the process. I always think, by the end of that session, you want to make sure that that family leaves and there's no doubt in your mind that they're going to take this on. They are going to refeed their child. We've had kids leave our first session and or families leave and take their kid to the Dairy Queen. Like, they're just like, okay, let's do it. That's, unusual, but it's happened. You want to have started using externalizing language so that the family is able to separate the illness from their child. And this is so important for parents who are very frustrated, probably very angry. Gives them somewhere to target that frustration and anger that's away from their child. Let's put that frustration and anger on the illness. And not everybody names the illness. It doesn't have to be that explicit, but it's a way of thinking about it as this isn't your kid. That's the eating disorder talking. Or some people talk about the voice. Like, now I know that that's the voice, that's not me. Really beginning that process of using that language. You want to make sure that the family's accepted the task of refeeding and that the family's prepared for next session's family meal. So session 2 is a family meal that happens in your office. You don't need a kitchen. So just very briefly talk about the nitty-gritty of that, you ask them to bring a picnic-style lunch. So you'd say, I know this is kind of a weird thing to do, but I'm going to ask you next time to come in and you're going to bring a meal with you. It's usually lunch. Some people stay late enough at work that they could make it a dinner. I don't, so I do lunch. You're going to bring a lunch. You're going to bring food for everyone in your family, including enough to feed your daughter or son who's starving. You don't need to bring food for me. I'm okay. I'm going to have my lunch beforehand, and some families have a really hard time with that, depending on cultural background. But it's too hard to, you be eating your lunch and trying to carry on this family assessment at the same time. And you'll ask them, bring all the cutlery you need, forks, knives, beverages, everything. So they're bringing everything with them. We have a microwave, and I'll say, there's a microwave if you need to heat anything up, but there's no full kitchen for them to use. It's nice to have a little table in your office. I just got a table for my office before I was trying to book the conference room. You have to figure it out. And then you have a family meal in the next session. Oh, sorry, this is an example of our FBT tracker, the weight graph over time. Okay, so session 2, the family meal. And you notice I've got a burger versus I've got some lettuce and tomatoes here. The family meal can be a great way to assess everything that's going on around food and eating. And obviously it's a little bit contrived because it's in your office, but I give people the explicit instruction at the end of the first session. I'll say, you might feel some pressure to make this go really well and to really impress me with how awesome everything is, but that's not why we're here. So what I'd like you to do is, I'll say to the kid, it's okay if it's really hard and the eating disorder voice is really loud. That's totally fine. And to the parents, say you might want to bring some food that maybe she hasn't had for a long time that is going to be really tough for the eating disorder. I don't want you to bring only safe things for her to eat today. So I really want to get a sense of what's going on. And then it's a great chance to ask during that family meal just basic questions like who sits where when they're at home? Is this normally, the way that they're sitting there? Is that how they would sit at home? Who does the groceries? Who decided what they were bringing for lunch that day? Where was their daughter or son while they were making the lunch? Were they in and out of the kitchen? What was mom doing? What was dad doing? What was brothers or sisters doing? And really get a sense of the family functioning around the meal. And you can also notice stuff at that time of, are all the family members eating the same thing? Is dad eating something different from the rest of the family? Is the kid eating something different from the rest of the family? And it's a chance to ask about that in a non-judgmental way, of course. And then near the end of the meal, you could ask the parents, are you happy with how much your daughter had to eat today? And sometimes they'll say, yeah, I think that was great. And sometimes they'll say, well, no, I would have really liked it if she would have had some dessert, but I was too scared to bring that. And it can be great to have a little bit of extra food in your office that they could offer their child, or if you notice that they're not feeding her enough during the meal, you can ask them to hold a little bit back of their own meal and try to get her to take one bite before the end of the session, because that can be very empowering to the family as well. So after session 2, this is very optimistic, the family is managing the adolescent's eating disorder. I forgot to mention that between session 1, session 2, session 3, and session 4, you might be getting frantic phone calls from the parents, frantic emails. And you need to tell people in session 1, this is really hard. The eating disorder is really going to freak out. They may be seeing some pretty extreme behaviors, so you need to be prepared for that during the first few weeks. They're probably going to be asking for individual therapy, inpatient unit, anything but this. That's okay. That'll pass. That's very normal. It's funny because I'm helping out a new staff member that we have learning this new approach who happens to be a social worker, and she told me they keep asking for a psychologist. And they've never asked me that because I am a psychologist. They ask for something different, but they'll ask for something different than what they're doing. That's okay. It's to be expected. This is really, really hard, but stay the course. Okay, so the remainder of phase 1 is more of the same. Not more family meals, but more, checking with the family every week or even twice a week if you can handle that many sessions at the beginning. You're weighing the patient at the beginning of each session. You're sharing that with the family, and the weight at the beginning really sets the tone for each subsequent session. If the weight is going up, then you're talking with the family about what, great work. What do you think worked this week? How's it going with meals? How's the pushback from the eating disorder? You're really keeping the focus on food and eating. Is she starting to want to talk to her friends more? You can ask the child how her eating disorder thoughts are if she's very open about that. When I generally ask the kid during the one-on-one phase at the beginning about binge eating, but I'll say something like, sometimes when you start eating again, the food just tastes so good that it can be really tough to stop, and I'm wondering if anything like that's happening for you. And that can be a way to bring that up with the family as well, because you also want the family to not let them overeat, right? So it's really very focused on food and eating. Okay, transition to phase 2. So this is when the child is going to be taking management of food and eating back in a developmentally appropriate way. So this is going to look different for a 10-year-old versus a 12-year-old versus a 15-year-old versus a 17-year-old. And it's also going to look different depending on what the family context is. And by the time you're in phase 2, you're going to know a lot about this family context and what things look like before the eating disorder. But the kinds of questions you can start to ask are things like, I'm curious about how things have been going really well lately and you guys are feeling really confident about Jane eating now and the eating disorder is not pushing back a lot. And you've already said that you felt comfortable letting her have lunch at school with her friends. I'm curious about how different are things right now compared to how they were before the eating disorder started. When you think about meals and you think about food and eating, and they might say, oh, well, she's doing really, really, really well, but she still doesn't, if we bake something at home, she's still not having that. And you can start targeting some of these very specific things. And many families kind of naturally start to back off a little bit and allow the child to have more independence, but some need a little bit more, what are some ways that you can gradually practice more independence again? At this point, during that transition to phase 2 as well, you might start exploring some of the relationship between adolescent developmental issues and the anorexia, or you might start bringing up some of the things that you've put in the parking lot from earlier on, really common ones being kind of over-control or perfectionism or anxiety. And if things are going really well, you can start weaving that into your therapy as well. Okay, and then transitioning to phase 3, which is the final phase of this treatment. They talk about weight goals in the manual, but for readiness to phase 3, but really you can have a kid who's 90 to 100% of their standard body weight, but their eating disorder cognitions are still very strong. That's not the time when you want to be transitioning. It's really more about how their eating disorder cognitions are. So once people are really able to think clearly, they're not obsessed with food, they're not watching the Food Network all the time, they're not concerned about weight and shape all the time, that's the time to transition to phase 3. And during phase 3, the focus is really on getting adolescent development back on track. So you know how you show your patients the weight chart that shows, well, here's where your weight was before, and now, ooh, you went way down off of your weight curve, and we want to get you back on that weight curve. In the same way, their adolescent development has gotten off of track. Maybe they weren't seeing their friends very much. Maybe they got out of all their extracurricular activities. Maybe they got into new extracurricular activities that were more eating disorder focused. So now is the time to work on getting their normal adolescent development back on track. And also, the parents, their own development as a couple, if it is a couple, you can also do this with single parents or with blended families. You need to focus on the parents getting their own life back too. Their life has been really derailed by this eating disorder. So you want to be asking parents, are you guys having time together? Are you able to go out now since you're not having to support all of the meals? And you model problem solving around adolescent issues with the family. What kinds of developmental challenges might be coming up? Is it a transition from elementary to high school? Is it a transition from high school to university? Is it beginning to date? Is it now their child's going to want to go out to parties that she didn't used to want to go to? Problem solving around these kinds of issues and trying to generalize the problem solving you did around the eating disorder to adolescent issues. These sessions are actually spaced 4 to 6 weeks apart, so although it only might be 4 or 5 sessions or so, you're spacing them far enough apart that you're able to see how they're doing over time. All right, so in summary, this approach really represents a new way of engaging families and helps them really truly be involved in helping their child recover. And it's also a real change in how interdisciplinary teams work together to best serve their patients. There are, of course, other therapies, which I don't have time to talk about in a lot of detail, but I've put a list of some of the ones that have empirical support. You'll notice that a lot of the treatments that are empirically supported have the most research done on them with adults, and we don't actually know how well they work with adolescents, with the exception of adolescent-focused therapy, which is what they use as a comparison treatment in a lot of these FBT studies, but I don't know anyone in Canada who's trained to do those. Okay. The bottom line, as Dr. Lam was underlining this morning, is that no matter what treatment approach you choose, the first focus has to be on the restoration of physical health through eating. So whether you do that through an inpatient stay, that's one way to do it, through family-based therapy, through a day program, or through some other approach that focuses on weight restoration, that's got to be the number one thing that you focus on. So this is one treatment approach that focuses on weight restoration and can be done at home and with a small team. For more training, to get certified in FBT, you can look at the Training Institute for Child and Adolescent Eating Disorders, and it involves workshop attendance and supervision. A great resource for parents and for clinicians is maudsleyparents.org, and these are the names of a couple of the books that I talked about earlier.